Welcome to tonight's presentation, PWS Behavior and Mental Health Issues, Information and Tips for Parents. Our distinguished presenter will be Elizabeth Roof, Senior Research Associate at Vanderbilt University in Nashville. Before we get started, though, I need to make just a few announcements. We had a tremendous turnout for this webinar, and I wanted to let you know that some of you will only be getting the audio portion of the presentation tonight. The first 100 registrants will be able to view the slides tonight, but everyone who registered will get an email after the presentation with a link to a recorded version that includes the full visual as well as audio version, so you won't miss a thing. The recording will also be available on the PWSA USA website for future viewing. Now, for those of you who are viewing the slide presentation, you'll notice that you have a dashboard on the right side of your screen. And in that dashboard, there are a couple of boxes. One is marked questions and one is marked chat. If you have questions for Elizabeth to answer at the end of the program, please put them in the question box, not the chat box, and she will get to as many questions as time allows after the presentation. I'd also like to give you the dial-in number and the access code for the presentation in case you get disconnected. Please write these down if you can. The dial-in number is 1-415-930-5321. And the access code is 992-990-533. Your lines are all muted to alleviate distractions. So if you have any problems or difficulties during the presentation, please let me know by typing in that question box, and I will do my very best to assist you. And now, without further delay, let me present to you Elizabeth Roof.
Hi, everybody. I'm so glad you guys could make it on a Wednesday evening, and I appreciate you giving me your time to talk about PWS. So I'm at Vanderbilt University, and since 1995 have followed about 325 kids and adults with PWS all over the country and Canada. And I'm really interested in talking with you about some of the things we've learned, some of the things our research has kind of uncovered, but also some of the kind of day-to-day tips that parents need to know to kind of best manage a kid with PWS. As you all know, they didn't come with an instruction manual. So the idea for us is to try to figure out what we can help you with, what makes sense, and what we know generally works over time. And so we'll talk a little bit about kids, we'll talk a little bit about teens and adults, and we'll talk about kind of how things evolve and what changes. So it may not be relevant to a lot of really young kids, but we see kids as young as 4. So we'll be talking about those. So the things that you're going to need to work effectively with somebody with PWS are listening skills, to be emotionally mature, to have patience, creativity, flexibility, and again, to be able to develop trust and long-term relationships. It's really difficult sometimes to listen to your kid with PWS, but it's really imperative that you find some ways to do that, because we find that so often if we can listen to what they're saying and what they mean and what they feel, we can actually help problem solve versus feeling angry and frustrated and things like that. So these are really qualities that you have to be able to work effectively for people with PWS. Next slide. So people often talk about professionals and experts and things like that, but the biggest factor that you have in a positive outcome is yourself, being a good parent. And I tell people all the time, if you can take care of you, you can better take care of your child. So this idea that you're going to focus all of your time and energy on your child is not going to serve you very well, because it's a little bit like running a marathon. If I sit there and, every day go, well, I really want to run a marathon, and I show up on the day of the race, but I haven't trained, I don't have the right shoes or anything like that, I'm not going to be able to do it. So for parents, this is a marathon. You have to take care of you and do some self-care. And parents who cope well with stress and changes in schedules are a really good role model for kids with PWS. They don't often like changes. They don't like things to be different. But if they see how you're dealing with stresses and changes, then they're going to be able to better deal with changes in their own lives, because they kind of see what that looks like. And if you're hitting the steering wheel and, freaking out because things don't go your way, well, that just shows them that you can't manage either when things don't go your way. So this idea that taking care of yourself and then managing and coping with stress is really important. Next slide. So people always wonder how much control they have over their kids' behavior. So this idea that everything is genetics, I often have parents who say, well, they've got PWS, so you've got PWS, that's because of PWS, things like that. If you look at the three circles, so parenting is one part of it, genetics is one part of it, and environment is another part of it. So this idea for parents is this idea that, you know, you are a part of it, genetics is a part of it, but it's not one thing that does everything. So even though everyone has PWS, each person is very much an individual person. So I think I may have lost the screen there. Is it coming up for you, Julie? Sorry about the technical difficulties, guys.
My computer has lost our visual here. Just give me a moment.
Okay.
Sorry about that.
Totally fine. It happens to me almost every single day.
I am going to cut the screen for a moment, and if you can go ahead, I greatly apologize.
Oh, it's okay. So as far as the genetics go, again, there's two different, you know, main subtypes, people who have a deletion, people who have UPD, and then some people have imprinting mutations or translocations. And so the deal is everybody has kind of the same genetics or the same little part missing that we, you know, that have PWS. But the idea is there's so much variability. We see lots and lots of individuals that are coping well, and we see people that aren't, and not all of it has to do with genetics. So I tell people all the time that parenting is a really big part of it as well. So it's important for you to know that you play a part, and you play a really big role as far as, you know, how your kid is, how they manage and cope. So I just, like I said, want people to realize that they have a lot more impact and kind of ability to change things than they think. It's not all genetics. Just like if somebody has a genetic predisposition to depression, doesn't mean that every single person is going to have exactly the same thing or the same severity. Hey, Julie, I'm going to pull up the slides on mine so I can keep on going if you're cool with that, and we'll just we'll go from there. So a lot of people go, now I've gotten diagnosed, so now what? What do we do now? So this idea that, you know, for people to realize that, you know, we have so much information, and if you know, had a new diagnosis and you kind of remember what that was like, this idea that we have all these things that people tell us to worry about this and to do this and to think about that. So the idea for a lot of parents is there's just so much information, and so it can be really overwhelming. You know your kid better than anyone else. So when it comes to experts or anybody else, you have to believe in yourself that you know your child best, you know what's going to work, and that you can try those things. It's great to get feedback, but you got to kind of trust in yourself and not be one of those parents who's constantly looking for validation out on the web or other kinds of things, and to realize that you are an expert about your kid with PWS. So some of the common behavior issues we see in children with PWS is delays in understanding, delays in motor skills, delays in speech. Even if they have speech, sometimes it's hard to understand. There's a lot of articulation issues. Compliance issues. They tend to be a little bit more stubborn. They tend to get a little bit more stuck. They have a hard time moving on. They can be pretty demanding about wanting things to be done a certain way, things like that. Also, temper tantrums are pretty common, where they get very upset over pretty small changes in schedules and in environment and things that they think are going to happen next. And most people will get that stubbornness is one of the really common features we see in children with PWS. So again, feeling stubborn, feeling stuck, not being able to kind of move on, and having to have it their way. As they get a little bit older, we see emerging food issues. Again, it's kind of an incessant, really intense hunger. Sometimes it's more that they're interested in food, but it's not about hunger. It can kind of vary from kid to kid. And odd repetitive behaviors, rubbing things, touching things. Sometimes they flap their hands. All those things are things that we see in people with kids with PWS. And then some of the other things are like sensory seeking behaviors. Again, doing things kind of over and over is really common in people with PWS. So We want to make sure that, you know, if they're sensory seeking, kind of what does that behavior do? What purpose does it serve? Also things like emotional outburst, again, being very emotional, very upset over really small things. And they can get to the point where they're actually shutting down and they don't take any more information. They don't listen to you. They don't talk to you. It's almost like nobody's home. Sometimes there's things like aggression. For younger kids, it's definitely more like biting and hitting. As the kids get older, they may take a swing. They may throw things. Those things are pretty common, and also avoidant behaviors. We have kids who go to the bathroom every time they don't want to do a class or they don't want to be in their classroom. So things like that are pretty common. And anxiety is pretty significant in this group, especially for some kids who just seem to be much more on edge, harder to relax, and harder to kind of cope with things.
Information thing about Prader-Willi syndrome.
So the next thing, I'm going to talk a little bit about some of these behaviors in a little bit more detail. The next one is perseveration. So I tell people all the time, it's like, if I like to talk about something, I like to talk about it a lot. So, and they like to do something until they're done, and they can't move on unless they're done. So this idea for some of our families is that their kid gets in this kind of endless loop where they're doing something over and over and basically talking over and over. So the idea for us is to kind of help them move on. So concrete reminders. To be able to say things like, okay, it's time for, you know, us to move on, or using like a clock, or, you know, schedules, tally sheets, anything that you can do. If we've done this 5 times, that's all we can do it. Also natural transitions. You know, I have people who ask me a lot about getting chores done or getting book bag packed or shoes on or whatever else. You know, I tell people all the time, you can use the old breakfast, lunch, and dinner as a really good way to kind of help move them when they're perseverating, and say, you know, as soon as you get, you know, your shoes on, we can have breakfast. As soon as you get your book bag packed, we can have breakfast. So using those natural transitions are a really good way to help people with PWS move on.
Is that new block? Oh, yeah, I got a new one.
So the next thing is anxiety in PWS. So anxiety is not always related to food and food-seeking behavior. I think people kind of get stuck on the fact that anxiety is about food. We have kids that don't have a lot of food issues but have a lot of anxiety, and we have kids who have a lot of food issues that don't have anxiety. So they're not always related, but many of the children with PWS feel anxious a lot of the time. There's kind of a low level underneath all of the kind of day-to-day stuff, and when things don't go as planned, then obviously the anxiety gets out of control. We also have people who are getting more likely to be diagnosed at a younger age than in the typical population. And in this case, it actually manifests with a lot of questions. What are we going to do? How are we going to do it? What's it going to be like? All those things are really, really common. They have lots and lots of questions and really need reassurance all the time. How's this going to go? What's this going to be like? Asking you for constant reassurance. So just realize that is the anxiety, and even though we don't always think about it looking like that, the constant need for reassurance is a really big deal for them. So I tell people all the time, it's important not to be a bottomless pit of reassurance, because I tell people all the time, you can't necessarily reassure your kid to the point where they're no longer anxious. So it's good to have limits and set limits and make sure that you're not spending all of your time reassuring them, because for people who are anxious, it doesn't matter how many times you say it's going to be okay, they're still worried and anxious about that. The other part that is really common for anxiety is to insist things be the same. So it's less anxiety producing when you know that things are going to be kind of the same. But all the time, it's kind of like the Groundhog Day. You know, Bill Murray woke up every day and the same song was on the radio, and he stepped in the same icy puddle and he talked to the same people. People with PWS would love it if every day was like that. That insistence on sameness and wanting things to be the same is really a big deal for them. So this idea that insisting that things be a certain way is important for them. But if you get a groove and you do the same thing every day and you make it so they don't have to adapt to change, you will find that it's way harder for them to manage any amount of change. So whereas we used to kind of say, stay on a schedule, do everything a certain way, we're saying less of that now. We need to make small adjustments, because we find that kids who insist on sameness and parents who accommodate it are way more anxious and much more likely to kind of melt down when things don't go as planned. Again, meltdowns are pretty common for anxiety. It's almost like a pressure cooker. They can only handle so much kind of steam before they have to let it off, and the letting off of the steam is a meltdown. And you will often find that when kids have a meltdown, they cry, they scream, they, you know, kind of throw themselves down. When it's all over, it's like it never happened. They completely reboot, just like your computer when you start it over. They completely are able to get past that. So this idea for us is that, it's important for us to realize that meltdowns are part of anxiety. It's not just bad behavior. It's not just a bunch of rage. It really is this idea that they've been dealing with anxiety all day. It boils over and they can't manage anymore. If they get to the point where they completely shut down, people often get worried about that. They say, I look at my kid, I talk to my kid, I call their name, they don't answer me. It's very common. That's that kind of rebooting period. So when that happens, you stay out of their face. You don't necessarily have to talk to them. You just kind of let them reboot and you let them do what they need to get back on solid ground. So the idea is when they're shutting down, there's just nothing to do.
What?
So can everyone see the screen? So for some of our folks, they have really kind of quirky questions. So, lots of information about different things. And, I tell people it definitely helps reassure them when you answer them, but they won't stop. So they often ask questions about schedule, about food, about other children. They need to know lots of details, and even people's pets. So there's a rigidity to some of their questions, but realize that there's some strategies to help manage them because we don't want them asking questions all the time and also coming up to strangers and other people and asking very, very odd questions. So again, it's important to have some strategies to stop them. We're big on 3 is the max. I often tell people, somebody asks me a question before we even get to that path, I say I only answer questions 3 times. So once we're done with 3 questions, I don't answer them. They think it's odd, but I don't answer them. And they'll often try to trick me by saying something different and hoping that I'll correct them. And again, I'll be answering. So I don't do that. I just look at them and go, you already know the answer. So redirecting them and saying, yes, we're going to Sally's house at 4 o'clock, and hold up your finger to let them know that you've answered it one time. The next time, yes, we're going to Sally's house at 4 o'clock. I bet you already knew that. And the third time I say, what time are we going to Sally's house? Well, we're going at 4 o'clock. Great. I knew you knew it. And that is the last time I'm going to answer it. So this idea that we limited them, we use our fingers to kind of show that, tally marks, whatever you want to do. And the helping them self-check is to let them know that 99% of the time they know the answer to that question. So realize sometimes the questions are actually to be able to stump you and to get you to say something different or to get you to say what they want to hear. So just be aware, 3 is the most that anyone needs to hear it. It is not a cognitive issue. It is not if you just said it the right way, they would understand it. They get it. They're trying to wear you down. And I tell people all the time, you're going to have to stop it because they can't. So when parents say I answer 150 times a day, well, that's really more your problem than their problem at that point because you're keeping this going. So as far as the stubbornness in PWS, I don't know how to say it, but they feel like they know how they have to be right. They feel like they're always right. It has to be their way, and they have to get in the last word. That's okay because they are the way they are. I think it's totally fine to basically kind of let them have the last word. If you have to have the last word and they have to keep chiming in, then at some point it's going to escalate to the point where somebody's either going to cry or get mad. So this idea that I don't always have to be right, I don't always have to have it my way, and I don't have to have the last word, which makes it way easier for them to be able to let something go. Some of the strategies that do really well with stubbornness is to allow 2 choices. I'm not going to push them in a corner and make them feel like they don't really have any way to kind of make control or have, the say in things. So I'll say, do you want to do spelling or math? Do you want to do this thing or that thing? And allow 2 choices. Let them pick and allow some level of control. Try to find a way to say yes. People always talk about saying no and being really stuck on that. But, when they say stuff like, well, I'm ready for lunch. Yeah, me too, but it's only 8 o'clock, so we have to wait till 12 because that's when we eat lunch, right? And they're like, yeah, right. Well, great. So find a way to say yes. If they want to do something that's maybe not reasonable, yes, we could do that after we do this, or we could
I'm sorry, we seem to be having some technical issues at the moment. If you could all hold on and be patient with us, we will try to get this resolved as quickly as possible. Our great apologies. Hold on. Once again, I'm terribly sorry. We are trying to get Elizabeth back online. If you could all just hold on just a moment, I'll let you know what's going on as soon as I know. There, maybe we have her back.
Okay, I think we're on the slide that says aggressive behavior now. So again, aggressive behavior really happens when anxiety and frustrations are really high. So just know that if your kid is agitated or upset about something, you really need to read their body cues. If they're pacing and agitated, you can really tell. So it's okay to validate feelings. It's not okay to excuse behavior. So like I tell people all the time, if I'm frustrated and I'm driving in traffic and it's been a really kind of a bad morning for me and somebody cuts me off, well, it's okay to be mad. It's okay to be frustrated. It's not okay for me to ram my Prius into somebody's car because I'm mad. So this idea that it's not okay to excuse behavior, I tell people all the time, I can tell you're mad. I know you're sad. I know you're upset about that. I understand that. You know, maybe we'll take a break, we'll calm down, but it's not okay to hurt others. So be really careful about saying that it's okay if you have a disability or you have PWS, that it's okay to hurt people. Doesn't mean that their behavior is not out of control at sometimes, because it is. But this idea that we validate feelings, but we don't excuse behavior. If they're getting aggressive, I don't actually do direct eye contact. I try to not look scared, but I don't necessarily look at them. So I usually look at the floor. I look at something in my hand. I act like I'm just kind of hanging out and no big deal here, because again, you want to make sure that your voice and your face are calm. You want to make sure that you and others aren't close to them. I have people all the time that get in their face or their space when they're upset, and they will swing at them and they'll hurt them. And then they're so upset. And I'm just kind of like, you don't get close when somebody's upset. If they're getting upset, you don't touch them. You don't try to physically intervene unless there's some safety issue where you're concerned that they might run out in front of traffic or do something like that that would be really kind of catastrophic. I don't touch them. I let them have their own space, because usually when you physically intervene, you are the one that gets hurt, and sometimes they get hurt. But again, there's no reason to do that if you don't have to. Give them a safe place to calm down. Beanbag chairs are a big favorite of mine, because they can kind of plop themselves down over and over and over in the beanbag thing. Seems to be a safe place to calm down. Don't let them be in a place where they can, break things or whatever else. Make sure other people are safe. Even if it means you have to put other kids or pets in another place, do what you need to, and have a plan before things happen. Prevention is the big key here. This idea that we're not going to always fix things, but if you have a plan, then you know what you're going to do. And some people use a code word for their other kids so that everyone knows this is what we do. It's almost like running a fire drill. If John gets upset, this is what we do. So I think it's really important to have a plan and to prevent it before we actually always constantly kind of have to diffuse it. Visual schedules and natural transitions. I'm going to show you a little bit about how to use them, what they work, and about consistency. If you don't use them all the time, they will not work. I have people who go, well, I tried the schedule, I did it for a day, and it didn't. Nothing works in a day. So you have to really stick to it, and you have to be able to kind of know that these are the things that work. And the next slide is actually kind of like, how do you brush your teeth? It breaks everything into nice little kind of small sections. It kind of gives them the, here's what you do. You can use a China marker or a dry erase marker, and you can have them click them off as they do them, so they know they got all the steps, they brushed them, they've done everything correctly. That's really helpful for them, because we often go, well, they should know how to do it. Well, they may, but they miss half the steps. So this idea that we can kind of break things down into little steps that they can follow, and it gives them a sense of accomplishment to know that they can click off these things as they get them done. I did this with my own 2 kids when they were getting ready for school, and we had a whiteboard, and they had to go, did you pack your lunch? Did you, take your vitamins? It was really great for them to know that this is the things that you need to do. And it also helps them be more responsible as they get older, because they're really doing a lot of self-care. Getting ready for school. What kinds of things do you need to do there? So this idea of walking them through the different things. And again, if it's getting ready for something, realizing that it's hard for them, they get stuck on a step or a thing or get distracted by something. So for them, they really need these little schedules, especially when they're younger. But even when they're older, it can be really gratifying to click things off, put a sticker in the spot, and to know that at the end of that, something good is going to happen. And sometimes that something good could even just be, we're going to have breakfast or dinner, or something like that. So just know that these are really great keys to helping them get on task and help move them along. Transitions are really tough. So how do we make them easier? I really love timers. I think they're so nice, because the timer went off. The timer went off. It's not you anymore. It's the timer, right? So using things like that, using visual cues. Some people use, emojis or colored things or whatever else. Anything that you can let them know that there's going to be a change, something's going to happen, there's going to be a transition of some sort. Having a heads up to kind of have a mantra to soothe your kid when they get in a transition time. So, change is going to do you good. You're going to be able to manage, change is not bad. You're going to be okay. Those kinds of things can be really, really helpful. And again, don't get too used to a groove, because repetition really does lead to intolerance to change. We're seeing more and more adults with PWS whose parents accommodated them in every single way. And what they found out is, oh, wow, now that they're adults, they really can't manage anything not going their way. So it doesn't have to be big, giant steps, but baby steps to kind of let them know that things are not always going to go as planned. And even though you'd like to help them make it not so hard, kind of realize that as a parent, that is something we have to actually do for them. So I always say the hard now, easy later, or easy now, hard later. So if your kid is younger and you're constantly adapting and trying to make everybody bend to the kid, you're going to find that it may be easy now, but it's going to be hard later. So the idea is that we want to get them to be a little more flexible, a little more cooperative. And the way to do that is to take baby steps so that they get how things go and they understand what's going to happen next. So let's say getting dressed for ready for school is hard for them. They don't like doing it. They get stuck. Here you are, they got one shoe on and the bus is here, that kind of stuff. Having a really good emotional outlook from you is a good way to get your kid motivated. So bright affect, you're confident and capable of getting the best out of your child. If you believe that, you will find that they really do gravitate towards emotionally positive people. So if you've got a frown on your face or you're irritated, they will sometimes just jerk you around because you're obviously upset. So this idea that, we don't want them to get stuck. And so for us, we're constantly like water, moving them along, moving them along. So realize that for them, they can be kind of slow. They have repetitive behavior. They're not always motivated to do things. They don't want to put on their shoes, and they have to do things a certain way. So just kind of realize that your job as the parent is to kind of help get that bright outlook, always pleasant, not upset, just moving them along. So one of the ways to do that is, again, to not have that kind of tone of irritation in your voice. I know it's hard. I call it my, flight attendant voice. Whatever's going on, I have just got the most upbeat and happy voice, and again, you will find that they really gravitate to that. You have to really believe it, because if you're faking it, they know it. But again, if you have a bright affect, you're calm, you're confident, if you believe that they will do it, they will believe. So this idea that you have to remain confident in yourself, and you have to be able to kind of see that sometimes things are hard, but your way of kind of motivating them is really just by being positive that things are going to work out well. So again, negotiating, arguing, bargaining, people often get stuck arguing with the kid with PWS. They will out-argue and out-stubborn you every single time. So I just tell people all the time, you got to get over yourself when it comes to that. So be clear about what the expectations are. If they're old enough, I like to get them in writing. We sign contracts for different things. We have them do things like that. Do these before the situation occurs, not on the fly. If you're going somewhere that you know is going to be stressful, some kind of family event, social event, have a plan of what's going to happen, what you expect from them, what they can expect from you, and follow it to a T. And again, if an argument starts, do not engage. You don't have to get the last word. You don't have to keep going on and on about it. And how can they control their emotions if you can't control yours? So the idea is we got to be the bigger person here so that they start to see what that looks like in a day in, day out situation. So shutting down, again, is common. What does it usually mean? That they're overstimulated, they're frustrated, that they have just been too stretched to be able to give any more, too upset to give a response, or too angry. You cannot make them comply when they shut down. So again, people will like drag them or make them do something. Don't do that. That is never, ever going to work. There's nobody home to even talk to. So at that point, let them get shut down, let them reboot. And at that point, just know that once things get better, they're going to be able to get back to it. But it may take a while, and there's nothing you can do to speed it up. The more you get involved, the worse it's going to be. And again, anticipating problems and respond instead of react. So have a plan, respond to it appropriately, but don't always react and blow your top when it comes to things like that. Things that help, again, visual schedulers, timers, limits on topics. We can only talk about this for a minute. Validating feelings, give them timeouts for cooling down. The timeout can be for you. You can literally say, Mom needs a timeout, go somewhere else, sit on the couch, do whatever you need to do, and just don't interact with them. But this idea that, you know, for us, it's not always about punitive, it's about taking a break when you need one. And then realizing that behavioral approaches, you know, combined with medication, especially those that target kind of compulsive behavior like SSRIs, and there are things like Celexa or Lexapro or Prozac, things like that, can actually help with some of the behavioral approaches as well. Also, being connected socially, vocationally, and recreational. If they're not doing stuff, you may find that it's way harder because they need lots and lots of structure. So if they're busy and engaged, they have less problems. If your kid is in school and you can get services with an applied behavioral analysis person, an ABA therapist, they can be really helpful because they can implement some of these structures at school and at home so that it makes it easier for you. And they can also take problems apart in a different way. As a parent, we often think about this kind of push-pull as far as what they want and what you want. ABA therapists can often see things about what are people getting out of a situation that's keeping these behaviors going. So for us, we want to be able to say, what is keeping these behaviors going? How can we kind of like take these things apart so we're not inadvertently making them worse? So what works here? Allowing them to calm down, letting them decide when they're ready to return to a situation. I tell people all the time, if somebody is having a meltdown or a fit and they're throwing things, I just go, well, you're obviously upset and I'm sorry about that. You know, my thought is you just let me know when you're ready to get back to it. And I literally look away. I pretend I'm doodling or whatever I'm doing, but I am not invested in them. I'm not paying any attention to them. I am just completely doing my own thing. And usually within just a few minutes, they're like, oh, okay, I'm ready. Well, great. You don't need to rehash. You don't need to demand an apology. This idea that somehow we need to like get them to say they're sorry. What difference does it make? Why can't we just be able to return to balance and not always have to be right? Because us being right means that they have to be wrong. So demanding an apology or having them say they're sorry, if it's not going to change their behavior and it's not going to actually make things different the next time, I'm all about just being able to return to the situation and being able to go, will you let me know when you're ready to get back to it? So I think it's really important to kind of get over that. And people will constantly tell you, parenting people will say that, well, you need to do that and you need to make them do that. I can tell you that those kinds of techniques, that authoritarian rule does not work well for kids with PWS. They really need I kind of say the iron hand and a velvet glove. You can't look like you're real tough on the outside, but you have to know where the limits are and what you're willing to kind of put up with. I'm going to talk a little bit now. I'm going to shift gears and talk a little bit more about some of the psychiatric issues we see in PWS. And these are more like things that would actually be diagnosable. So they're not traits. They're not just kind of behaviors. They actually can be a point where we're actually talking about a diagnosable kinds of things in PWS. So some of the ones we see often are attention problems, anxiety, depression, other mood disorders, so maybe not depression, but something else, aggressive behavior, and it can be to the point where it can be incredibly significant, where there's actually some risk of safety or other things for parents as far as worrying about their kid actually hurting themselves or hurting somebody else. And I'm going to talk a little bit about psychosis. That's gotten a lot of press, and that everyone has it and that everybody. But I want to talk about what it is and what it looks like, so that you can kind of know what to watch out for and what kinds of things may head it off before that happens. But a lot of it is really just seeing it and knowing what it looks like. So I'm going to talk a little bit about that too. So anxiety and PWS, again, how much does it impact them? How much does it distress them? For a lot of folks that we see, they're not really impacted by anxiety unless they don't kind of get their way. But for our parents, they're usually extremely impacted by anxiety. Their kids asking questions all the time or doing things over and over. So some of the typical anxiety medications don't work well in PWS. Generally, you don't see a lot of people taking them. Again, so there's some have some pretty significant side effects. And again, they're not made to be used for long-term use. So for some of our folks, they're taking an SSRI like Celexa or Lexapro, Prozac, Zoloft. And what we find is that for most of them, they're starting at a really low dose and they're going up very slowly. So we don't know why, but they don't seem to respond the same way that a lot of typical folks do to some of the medications. And they definitely don't respond to like a normal starting dose. So we have people on incredibly low doses and it seems to work well. So again, looking for side effects, looking for monitoring. And I'm a big believer that daily diaries, like writing stuff down so you can remember it, is really, really helpful here. As far as depression, it's not very common in PWS. It's about 8% of our samples. But I will say that the symptoms are harder to determine because sometimes the things that we were looking for in people who are depressed are pretty common in people with PWS. So where does it change? So sleeping too much, being overly hungry, being kind of lethargic. Well, a lot of people with PWS are like that. So they are a little bit harder to tell. But again, looking at changes, how they were before, how they are different now. And the things that we see most often with depression are withdrawal, irritability, annoyance with others. They can be very tearful, and sleep issues. They stop sleeping or they sleep all the time. So again, we're looking for changes or something that's different. And we know that people who have a deletion versus imprinting mutation in UPD can actually have some differences there. So again, depression is one to watch for. It's not as common, but again, know that all the typical symptoms in PWS and in depression don't always look the same. So look for changes. If something in your gut tells you that something's different, then you should be aware that it could be depression. So we get a lot of people who ask us about bipolar. We just do not see very many cases of that. So again, it's funny for some of our folks like in the EU and Britain and other places, bipolar is not a very common diagnosis. It's been about the same, about 5% of all psychiatric disorders is true. But in the US, it's become an incredibly big thing where people are starting to use bipolar as a kind of a catch-all diagnosis. And several people with PWS are getting diagnosed with it. So I just tell people, if it doesn't really inform treatment and the treatments aren't really effective, then maybe bipolar is not the issue. Mood stabilizers are often used for people with bipolar. Newer versus older medicines. Sometimes the older medicines just have a lot more data behind them and people have used them a lot longer. So generally, I'm a big believer that some of the older medicines can be more effective than the newer ones. But again, a lot of the bipolar medicines have some pretty serious side effects. So again, monitoring, looking at accountability, like what exactly are they taking them as they're supposed to, and not letting them take their own psych medications. I've had multiple people with PWS who are taking their own and they're pocketing the pills or they're putting them in a plant or they're doing something else, and the parent goes, well, their behavior is just awful. Well, do you really know that they're taking them? So parents giving them to them and making sure they're taking them is a really important thing to do. Psychosis, again, how common is it? We keep seeing 80 to 90%. We have about 7% of our population that we see out of like 300 that have actually had it. And it's not limited to those with UPD. If your kid does not have UPD, it does not mean they cannot have psychosis. So the common symptoms that are overlooked are withdrawn, confused, disheveled appearance. I see people all the time and I'm like, this is new. So you're looking for something that's different. They're not showering. They're not, they just look, their hair's uncombed. They just look different. Unable to carry out daily activities, changes in eating or sleeping patterns. Sometimes they will stop eating or not eat as much, and people are like, yay, we've got that under control. That is usually a symptom of early psychosis. So if your kid stops eating or they're having to be called to dinner and things like that, it can be a precursor to psychosis, but also odd thoughts. So They often have odd thoughts, but they become much more prevalent. They talk about things all the time. They kind of get stuck on things. Paranoia, and realizing you can't fix this yourself. It's not something you're going to be able to do. So having an emergency plan, and also know that safety first. You're not going to worry about them gaining weight. You just can't. If they're not safe, then you need to actually get them to a place where they can have help, and usually that's a psychiatric hospital. So medications can be the cause of it. Sometimes they've started something new, or they are having an odd reaction. Think of everything. We're looking for stressors or environmental changes. One of our biggest precursors of psychosis is a big change in school or home. So they're actually not going to school anymore. They're at home more often. Anything that's stressful, and it doesn't always have to be a bad stress. It can be a good stress, and that can be really, really tough. So again, treatment is needed quickly. It does not get better on its own. It does not go away. And if somebody just tells you and your gut says, it feels weird, but they just tell you this is PWS, find somebody else and keep going until every kind of avenue is exhausted. And also prepare like the psych hospital to deal with food. There's a really good, PWSA has a really good booklet about handling food and things like that. That needs to go with the kid when they actually go to a psych hospital. And again, medications, the right ones can work really quickly at the right dose and the type. And just because you are better doesn't mean you should stop taking it. I have people who stop taking it and suddenly they're psychotic again. Generally, it seems to be something that's going to need to be a kind of a constant thing, and it's going to be something that's going to need to be done every day. So you can't wean yourself off of it and think that it's not going to come back. So for some of our folks, they've had multiple psychotic breaks as soon as they stop or change the medication. Things that can make psychosis less likely: being socially engaged, having expectations and supports to meet them, having a job, having school activities, physical activity is really good, recreational activities, hiking, doesn't really matter what it is. It has to be things that they look forward to, and a family time with structure. If they're sitting around on the computer all day or goofing around on TV or doing nothing of structure, those are the people that we find that isolation, being withdrawn, tends to have psychosis to be more likely. So if your kid's not engaged, they don't have activities and things to look forward to, they're more likely to have some kind of psychotic or depressive episode. Realize that you're part of the team. Make it work. I'm going to talk just a couple minutes about some of the things that work for working with a provider and kind of what you do and what you don't do. But if you're talking to a provider about your kid and talking about medications, don't make it about a venting session. You're not trying to be there. Don't have your kid in there the whole time. You're going to have to talk really honestly, and don't get sidetracked into other issues. Don't be late. Don't be disorganized. I'm a big believer that having a list and focus on things is a really important thing. And again, it's not about you. You want to spend the most amount of time thinking about things that you can do to help your kid. Bring a tip sheet about your child. What's unique about them? What do they like? Those kinds of things. When do problems begin? What have you tried? What's helped? What hasn't? Tell about the issue in precise terms. Don't use things like they're freaking out or whatever else. Say things like he has, an anger outburst or a temper tantrum, those kinds of things. When it happens, how long does it last? When does it happen? Look for patterns. Is it at the beginning of the day? Is it at the end of the day? Are they tired? Like, what other things can we figure out? And ask teachers and other people for input. Writing it down. Don't trust your memory. You're not going to remember when you're kind of put on the spot. Medications you've tried. What have you tried before? What are the side effects? How long have you taken it? Why did they stop? Those things all matter. I've had more people go back on a medication that didn't work because they couldn't remember if their kid had been on it or not. So writing it down is a really good thing to do. Know that initial visits may be longer, but make the best use of your time. Listen, but ask questions when you don't understand things. It's okay. You're not a psychiatrist or a provider, so that knowing that if you're not sure, ask questions. And again, have a friend go with you and take notes or help process things. Those are some of the most important things you can do. So I feel like I did a lot of information in a pretty short amount of time, but I would love to take questions if we could do that now. And if I can't get to all of your questions, feel free to email me, because I am happy to talk to anybody if you want to email me.
Well, we have a few questions that have come in. We have not very many, though. So, folks, if you have questions, type them in that little question box that's right about midway down your little dashboard. We have one question, Elizabeth, about the difference between school district testing for things like learning disabilities and attention issues, as opposed to testing that's done in a more medical situation. A mom asked that the school district has tested her child and said she has no learning disabilities or attention issues.
Mm-hmm.
And she's wondering if a school diagnosis like that can be trusted or if it needs to be pursued further with more medical testing.
I mean, that's actually a really good question. So, you know, before I did this, I actually worked for a neuropsychologist. So that's what I trained at. And I would say that sometimes schools have a vested interest to keep people from getting services. So sometimes if there's, you know, a diagnosis that's kind of on the border, they're much more likely to say, yeah, they don't really have it. I would look at the actual scores and see what you think. It sounds odd that somebody, and maybe they don't have a learning disability. That's usually a definition of academic achievement is lower than cognitive ability. So if they're kind of relatively the same, their cognitive ability and their academic achievement are about the same, they don't consider that a learning disability. But if you definitely have a specific question and you don't think the school has done kind of like if your thought is they definitely have attention issues, then I would go to your pediatrician or somebody else and see about the possibility of going to like the child development center, somebody else they can refer you to, and maybe focus on a specific issue, which can be much more kind of economical than kind of the scatter approach where you do a really big evaluation that may end up costing a lot of money. So those are definitely things to think about. And I will say that I do find schools sometimes are less likely to give a diagnosis, but not always. It really varies from school system to school system. At the end of the day, it's about resources. They only have so much money, so you know they're not going to want everyone to get it. So I would look at those scores and see what you think, and maybe show them to somebody who's outside of your school district to see what they say about that. But that's a great question.
Very good. Here's another one. What if your child demands that you apologize in a situation, even when it's not appropriate for you to apologize? Do you do that just to move on, just to move things along, or do you point out to them that you don't owe them an apology?
Yeah, that's a tough one. I mean, my thought is if the pointing it out is never going to work. So that's definitely not going to work. Saying that, they did something wrong. If you wanted to even give the kind of, apology where you're like, I'm sorry for my part of it. If you could even say, I'm sorry I argued with you. I'm sorry but maybe what you actually did instead of taking credit for all of it. Because like you said, you know for a fact that, but I don't think pointing it out, because when they're upset about it, a lot of times they can't get past it. So I would say I would apologize for whatever I did wrong. And sometimes it's just that I mishandled it. I didn't respond the way that really works. And I know better than that. That's okay to respond to, and that's okay to apologize to. So I would say that would be okay, but I wouldn't make any blanket kind of statements that you're taking responsibility for everything, if that makes sense.
It does. It does. So how about this one? Do you have any tips for going on vacation? This father says his son has a really hard time with changes in plans.
Mm-hmm. If you can allow them some level of control. So like I said, maybe they get to pick an activity during a day. People often like to talk about downtime and unstructured time, which is what you need for a vacation, but it's not what they need for a vacation. So if you can make part of the day somewhat structured for them so they understand when they're going to eat, when they're going to do different things, so that they have, I would even like make a schedule for them on the vacation, because again, what you need is not what they need. So I would say that giving them a heads up. You might even have a time where you're like free time, who knows what's going to happen during this like hour block. It's okay to do that, for 1 or 2 hours a day. It's not okay to have no plan and just say they have to roll with it, because that's going to be really stressful for them. So let them have some control, maybe even give them, kind of the responsibility of planning an activity or something they're going to do. And again, you take all that kind of nervous energy and you turn it into something productive. Maybe they, try to do a scavenger hunt or something. Anything that feels like it has structure, they will be excited about. So just realize it may not be as relaxing for you, but that's what they're going to need to actually be able to cope, especially if it's an entire week within a family and they're not at home. That is very stressful for them.
All right. We have another question. Has anyone studied the use of mindfulness and or DBT, which I'm personally not sure what that stands for, but you probably do, in the PWS population?
Yeah, it's a type of therapy. So mindfulness, there is a group actually out of Australia that is doing exactly that. They're using mindfulness to see if they can help some of the temper outbursts, kind of behavioral, emotional regulation. So they're using exactly that. So my thought is I would stay tuned because I know that that study is going on now, and they're hoping that they're actually training parents, but they're also training kids with PWS. I think it'll be really fascinating to see what that does. I mean, I definitely think if you have a kid who's insightful, who can use those techniques, that's fantastic. I will say that when they get upset, it's sometimes hard for them to access things they've already learned. So even though they may know how to do things or they may know how to de-escalate, it may be harder for them when they're upset. But I do think that being able to kind of calm and self-soothe is a really important skill to have. So there's nothing wrong with teaching those skills, working on that. DBT usually requires a pretty high level of kind of insight and ability to kind of, I don't know, identify things that you're kind of like doing that are not working. So I don't know anybody who studied that. I would say that I can't think of a ton of kids that would probably do well at that. There may be a few, but that to me is a harder, more abstract concept to kind of get for them. So that's my thought there.
All right, I have another question about a young lady having trouble getting through the school day. This mom says her daughter seems to shut down toward the end of school, falls asleep immediately when she gets in the car to come home, and mom is wondering if it's ever appropriate to end a school day earlier or possibly allow her a nap time during school. What are your thoughts on that?
That's a great question. I do think that their like physical stamina generally is not as high as a typical kid. I think if she's having, if her behavior at school is quite good and she has got it together, but at the end of the day, she is completely spent, taking a nap or ending it earlier is really important because again, you get to see her as a kind of a wadded up piece of tissue, but she came out in the morning as, you know, she was great. So it's kind of a bummer for parents to know that their kid was so great during an entire school day, but all they see is kind of what's left at the end of the day. So yeah, I believe that having a shorter school day, having a nap, anything that you can do, because I truly believe that that really is hard for them to get through a day of 8 hours with all the demands and all the expectations that are there. So yes, I think that would be great. If she's older, it may be a little harder to get the school to agree to that, but if she's younger, I think it can be a really effective thing. And sometimes when they wake up from even like an hour-long nap or a 30-minute nap, they are amazing after that's over. It's almost like they completely just kind of, you know, refresh themselves and are able to really make it through the end of the day and learn something. If they're sleeping or so tired, they're not going to be able to really learn anything.
All right, I have another question about diagnosing psychosis. We have a mom who reports that her teenage daughter has started hearing voices and reports that people are speaking to her through the walls. And mom wants to know if that could be a symptom of psychosis. And if you think it is, what should be the next step?
So that definitely sounds like psychosis. So when you get to that point where you're hearing people talk, and I've had multiple kids report it even when parents didn't know it. Like they'll say, I hear people talking outside my room. They believe that there are other people in their house. I would, you know, as long as she's not self-harming, I would definitely bring her to your provider's attention, you know, pediatrician, adult doctor, whatever else, and see if you can actually get referred to an appropriate psychiatrist. But sometimes you may find that, you know, regular internal medicine people, that's not their specialty for sure, but sometimes they deal with those things. So I would bring them to the provider's attention first and see what the next step is. Because for most people, it's hard to see a psychiatrist unless you're already seeing somebody. So getting a referral and finding somebody who's good and an appropriate referral would be really, really important. But yes, I would definitely take action. That sounds serious to me.
And we have several questions from parents wondering the length of time that their children should stay on antipsychotic medication. One mother of a 15-year-old wondered if her daughter will need, who actually has a psychosis diagnosis, if she will need to stay on her medication for the rest of her life. Here is another parent who wonders if their child will need to stay. she's been on a particular med for 20 years, wondering if she should need to stay on that med for forever also.
Yeah, I mean, if they've had a psychotic break in the past, I think it's really important to stay on something that's working. I mean, if they're not having any psychotic symptoms and they're doing well, I definitely think that staying on it. We also have seen people who've taken an antipsychotic for behavior control, like they're taking it for a different reason, and it's used for that. Like Risperdal is used a lot for people with irritability and impulse and anxiety. It's been used in autism a lot. Some of those people are not having psychotic episodes, and we're wondering if it's actually kind of staving off those things. So my thought is if it's working, stay on it. But if at some point you feel like it's not working or these symptoms are coming back, then it's important to talk to your doctor about other options at that point, or, dose increases or something. But yeah, generally we have people that are on, a antipsychotic if they've had a psychotic break for many years. I can't say forever because, I don't know, but for a lot of our folks, they're taking it and have been on it for a while. So I would say if it's working, stay on it. If it's not, look at other options or dosing or anything else. But again, having a psychotic episode is a huge disruption for a family, and it's a huge problem for kids with PWS because, again, it's like falling off the train tracks. We want to get them back on a kind of reality and those kinds of things. It's just imperative to actually have that on board so that we don't have people who have multiple episodes of psychotic breaks.
All right, here's one that people are wondering about. How can I help my son's younger brothers understand his anxiety, questioning, and such, because they get very frustrated with him? And I think that's very common, that sibling issues.
Yeah, I mean, that is actually a really great question. So, now that I've seen a lot of people who've been like little kids when we saw them initially, now they're grown up, I will say that if you can find something that the other siblings have that they're not good at, I have no sense of direction. I can't tell left from right. I still, as an adult, can't do that. I'll often use that as an example. Everybody has something they're not good at. Everybody's wired slightly different. So if you can take your younger sons, something they're not good at, maybe they're not athletic, and kind of say that everybody has things that they're not good at that are harder for them, and kind of get them to be empathic in a way where they start to realize that not everybody is kind of starting out with the same issue. And even though it's frustrating, can you imagine if you didn't, I laugh, my husband, I don't have any sense of direction, so I really have a hard time like finding my place when I'm out driving. If he yelled at me, would that make me feel any better? No. So the idea is that we are kind to people, we're compassionate, we realize they have different needs. So I would focus on that part of it, that everyone has different needs and they're made differently. So focus on that and the things that they're maybe not so good at. So they start to realize that everybody has something they're not good at and they struggle with.
That's very good. Another mom asks, do you find psychosis type issues more common in those that are transitioning out of school around that age 22 or so?
Yeah, that's a great question. Yes, we do. We find that not being in a structured setting, not having the kind of supports, being kind of socially isolated definitely sets people up. So we've had multiple people, and maybe not even those with UPD, who have left school. They've become very kind of sad, distraught. There's nothing to look forward to. Their day feels like it just kind of goes without any structure. And we do find that. So I would say that's definitely the kind of the mid-teenage years, we see a little blip in some kids, and then early 20s to like 25, we see another blip where there's definitely much more kind of prevalence. But we do have people who are in their 30s and 40s who are having their first kind of psychotic episode. Most always it starts with some level of depression. So getting that diagnosed and getting that treated can actually stave off psychosis as well. So if somebody is withdrawn and tearful and irritable and everything else, if that goes unchecked and not treated, it can lead to psychosis as well. So I would say that watch for it, look for those signs, because I tell 99% of the time, those are the signs that we see every single time. When people talk about it after it happened, always disheveled, not sleeping, confused, stuck on things, just really, really odd. Those are the behaviors that we see. So look for those. If you see them, deal with them.
Excellent. We'll take just a few more, do you think?
Yeah.
All right. Here is a question about a young adult man. He's 34 years old and has been getting more and more emotional outbursts and difficulty controlling his emotions, which is new to him at his age. And his parents are wondering if it could be the testosterone medication that he's been taking that could be doing that.
Yes. Well, it depends. So if the testosterone is new, or it's been in the last few months, yes, we have seen some kids who get much more emotional. If it's something that he's been taking for a while and this is a new behavior, the outburst, the irritability, the kind of just emotional dysregulation can also be depression. So we're seeing more and more people who just aren't getting diagnosed with that. So I would, again, is he feeling sad? Is he feeling like, do people annoy him all the time? I would ask those questions. And if that's the case, I would look about the possibility of, do we need medication to help deal with some of those things? But if testosterone is new, yeah, anytime you change meds or add something and you see some odd behaviors, it can definitely be related to medicine. So just be aware it's a possibility if it's a new medicine.
All right. I have one more about psychosis. Here is a young lady who recently had a psychotic episode that lasted 1 week, and it was dealt with and has resolved, and mom wants to know if it's happened once and resolved, is she more likely to experience this again in the future?
So for a lot of the kids that we see that have a psychotic episode, if it's treated and then they get off medication, like for whatever reason they say, oh, well, we resolved it, we do see that they can relapse. So I would tell people it's not like a given, but we definitely see people who have a psychotic break. If it's treated with medicine and they stay on the medicine, it's quite possible that they may not have any other problems. But if they've stopped taking medicine or done other things because they think it's good, we're gone, then sometimes we will find. We've actually had one young lady with UPD who's had 7 psychotic breaks over a period of like 20 years. So she gets better. The person takes her off medicine because she's better. And then, a couple years later, she has another one. So my thought is if you can keep her on a low dose, almost as a prophylactic, if that's what she's doing, then that might be a good kind of safeguard. But again, talk to your provider about that. What do they think? But we definitely see people who relapse and have other psychotic breaks.
All right, here's one that I think applies to a little bit younger children. If your child denies that they sneak food and they lie about it, what is the best strategy to deal with this? And is there any hope that they can learn not to do this? Or will, as this is phrased, will they always default to their genetics?
Yeah, that's actually a great question. So my thought is, and I tend to be a little bit more negative. I think the lying about it is just, they know they're not supposed to do it. They know, but they're going to do it. So my thought is, it's a little bit like anything else. I don't make it so that it feels like I'm, confronted them or anything else. If they've taken food, all I do is I say, well, this is missing, because of that, I'm going to have to adjust your calories, your menu, whatever you want to say to make up for that missing thing. And you leave it at that. So you deal with it in a very kind of matter of fact way, because it's like this. If I had a new baby, and I remember this very that you literally would be so sleepy that no matter what it was, you would find yourself falling asleep. If my boss said, I'm going to fire you, Elizabeth, if you fall asleep, but I'm so tired and I fall asleep, is that really something, again, that, somebody should be able to be punished for? I don't think it is. I think it is biology. So I think for food, the taking it and not admitting it, it's just, that is how they're wired. So I just say it's missing, it's a fact, here's how we're going to do it, and just be very upfront about it. And then I don't talk about it again. And I'm much more careful about access, security, and monitoring. So it's the onus is on me as a parent or whoever to make sure that they don't have opportunity. It's not fair to put it on them. And no, I do not think they learn how to do that. I see adults who are 60 years old who still would take food if they got a chance. It's not fair to do that to them, I don't think, to actually give them responsibility for something that's biological, just like sleep.
All right. Here is a question about bedtime. My daughter has many questions at bedtime, and we're having trouble limiting these questions. They're very repetitive and can take up to 45 minutes to get through. If we don't answer her question, she has temper tantrums and resorts to soiling. Do you have tips for us?
Yeah, so limiting them to some degree. So my thought is I would have a question time. I would set a timer depending on what, you'll have to work from 45 minutes back because you're not going to go from 45 minutes to 4 minutes. But my thought is say you get 10 minutes to ask questions or 30 minutes or whatever. My thought is that she's doing it for some reason, and it may be that she doesn't want to go to bed, or it may, who knows, you're prolonging it. So it's just like a little toddler. If a toddler doesn't want to go to bed, you don't sit there and talk to them and hopefully they'll go to sleep. You need to have a schedule and an expectation. And I would just tell her that this is what we're going to do because mom is exhausted. Mom has to go to sleep, and say, well, you get, literally this many minutes or this many questions. You guys decide what would work for her. And if she has a fit or she soils herself, if she's old enough, I would literally have her, take off the sheets, do whatever. Do not make it so that you're cleaning up after this child unless she is completely, if she's old enough to soil herself intentionally, then she could actually do the laundry, take the sheets off the bed, whatever. You don't talk to her, you don't give her any attention, because again, when she soils herself, then you're spending a lot more time dealing with that, and she knows that. So you really need to find a way for this to be the end of the night so that she can actually know that this is what's expected. And even if I do all these crazy things, they're not going to let me get away with it. You don't have to punish, but you don't reinforce.
All right. Do you have any tips for elopement in adolescence? I think that's pretty common too.
It is.
That's a common thread.
Yeah, I think some of it's not getting them so upset that they feel like they need to elope. There feels like there's a real biological need that when they're really upset that they just have to like leave. So my thought is there a safe place they can go? Is there a place they could go walk? You have to kind of think what works in that situation. But I feel like when they're in that mode where they're so upset, they just have to go. So if you can find a safe place for them to go, follow them at a safe distance, whatever you need to do is a way to go. But a lot of it is trying to preventing them from getting so overstimulated or so upset that that's the only option they have. So is there something you could do before they get to that point? Can they find a thing for them that feels, like similar kind of like thing? Could they go into the backyard? Could they pace? I don't know. But again, I feel like that is such an interesting thing. And when kids do it, even if after it's happened, they often can't tell you why they did it, what they were like. They don't know. It just feels like it's just they have to get away. So just as long as they're safe, that's all I can tell you.
All right. We have a question. Actually, we have quite a few questions about sleep and getting kids to sleep. What do you recommend for improving the quality of sleep? These several children who wake up in the middle of the night and then are overly sleepy during the day, and just your general recommendations.
Yeah, I mean, sleep is so important to people with PWS. So, if you haven't had a sleep study, I would go there. I would start with something. Is it medical? Is there some reason they're waking up in the middle of the night? And again, even we have kids that are going to bed as early as 7 or 8 o'clock at night. And my thought is that's how much sleep they need. So even though it seems like an excessive amount, maybe it means they need to go to sleep at 7 or 8 o'clock because they need sometimes 13, 14 hours in order to be able to kind of function. So, this idea that we have to kind of adjust their life to work around that. The other thing is, again, if they've had a sleep study, do they need a CPAP machine? Are there other things that we could do? And if they're waking up at night to go to the bathroom or do whatever, then I would make sure that they don't drink too many liquids. I mean, it's all those kind of common sense things, not too many liquids. What are they doing when they get up? Are they wandering around? Are they reading or whatever? No reinforcement. So if you get up, you go to the bathroom and you get right back in your bed. I always tell them, I can't make you go to sleep, but I can make you not interact with people or have anything fun to do. So don't reinforce it by talking to them or having whatever. Go to the bathroom, go back to your room, just no reinforcement. But again, it is imperative that they get good sleep. So rule out medical stuff and then just do those kind of tried and true kind of kid techniques that work to get them back to sleep so that they can go back to sleep as quickly as possible.
Very, very good. We've gotten a couple of questions now about comorbid disorders. Things that coexist in one person with PWS, and a couple of questions specifically about PWS and disorders like Tourette syndrome. Do you see that often, and how is that managed?
We don't see it terribly often, but we've had a couple kids who definitely have Tourette's or some kind of tic disorder. So some people use stimulants. It can sometimes make it better, but sometimes it can make it worse. So that's one option. But if they have Tourette's, usually medication is like the only thing that's going to kind of help that. So I would just make sure that the diagnosis is accurate, and then whatever treatment that they use doesn't have the unwanted side effects. Because for some of the people who take stimulants, it can make you more anxious, more agitated. So just again, be aware that some of the medications that work for one thing can make something else worse. So it's just that balance of what's, something we can live with, what's something that the kid can live with, versus this idea that we medicate everything because it may make something else worse.
Very good. Can you speak to the use of CBD oil in anxiety behaviors in PWS? We have a lot of questions about that.
Yeah, I do too. I tell people all the time, I don't have enough data. So until there's a placebo-controlled study for CBD, I'm just not going to recommend it. So again, I have parents who are giving it. They swear it's the end all be all. That's great, but I need data. So my thought is if you want to try it and you have somebody who's willing to kind of help do that, but I just think that without the data, I just don't feel good about using that as a modality when there are other things sometimes like SSRIs that work better for anxiety. I mean, they are proven to work in PWS.
All right, here's another question about the possibility of growth hormone helping with behaviors. We have a late teen who is diagnosed just coming into the teenage years and not been on growth hormone, and the family is wondering if putting her on growth hormone at this point could help with some behaviors and with sleepiness.
It definitely seems to help with sleepiness. So it gives people a little bit more kind of energy, alertness, things like that. I have not seen it make a difference on behavior problems. So, nothing that I've read or seen makes me think that it would help that. So my thought is, it should help other things in a physical way, but I have not seen it actually help or even make worse behavior problems. So I would say if you try it and it seems to help, that's great. And they're still having behavior problems, look at other options for either medications or therapies that would help those things. I think being diagnosed late is also hard because, again, you didn't know they even had this. So again, maybe talking to some other professionals and trying to get an idea of what's, kind of typical and for PWS and what may be unique to this young lady. So I think knowing that, but I would say that I don't think it's going to make a ton of difference in the behavioral part of it.
All right. Can you speak to your recommendations for skin picking?
Yeah, so skin picking is kind of a hard one sometimes because, again, some people, Jennifer Miller and Morris Angulo, did a kind of a small study looking at something like Pharmanac. That works for some people. Some people, it is covering it and not letting them have access to it. That helps. Keeping their hands busy sometimes helps. It really depends on kind of why they're doing it and when they're doing it. So if they do it when they're sleeping or they're not even aware of it, then a lot of those things won't work. But if they're doing it intentionally or they're bored or whatever else, then they need to be kind of kept busy. So the idea that for some folks, it really is just kind of wearing long sleeves, trying to keep things covered, knowing that when there's an imperfection, their hands are just drawn to like a mole, a freckle, an ingrown hair. So just knowing that those things are really hard for them to leave alone. So, again, some people use Pharmanac and it seems to help some people. And then for other people, it's those more behavioral techniques. So do those things, figure out what works, and try things until you kind of hit on the thing that works. Because again, we have different kids and different individuals, and they're doing it for different reasons. So I think that really matters, like why and when they're doing it. So maybe start kind of looking at that and trying to figure out what it's doing. Are they bored and just kind of like not have anything else to do but pick their arms, or is it something else?
All right. And then do you have any recommendations for handling difficult behavior in public?
Yeah, that's always tough. I feel like kids with PWS know that they got you over a barrel and they're like, So making expectations pretty clear, having a contract is sometimes good. So if somebody does something that is disruptive or, harmful or anything like that, then at that point, then I think we need to, have a plan. Is it one parent goes home with the kid? What do you need to do? I kind of don't like to spoil everybody's fun, but I also think that it's important for the kid with PWS to know that that's not okay. You can't do this and hold us all hostage. So, I've had parents where I say, you got to pack it all up and just go take them home. So that idea that if they do it, they understand the consequences or they don't get to participate in some event. So just know, they know that you're much more likely to give in to them when there's a public forum. So I have stepped over more kids, when they're falling apart, and just, I won't give them any attention. So doing those things and realizing that no matter what they do, we've already agreed upon this. This is our plan. This is what we're going to do, and stick to it. You do it a few times, they start to realize, wow, she's really going to follow through here. And you want to be that parent. They need that.
All right. What is your opinion about the use of oxytocin, and do you think that will have an impact on PWS behaviors?
Yeah, I mean, the data is still, the jury's still out, but I feel like that's definitely something on the horizon that may be effective for certain kinds of behaviors. It's not going to fix everything, but it does seem to make kids less anxious. It does seem to make kids, somewhat more cooperative and things like that. But again, it's another one without the data and the dosing and everything else. I think we need to be really careful that people aren't self-administering these kinds of medicines to their kids without a professional's advice. So talk to your doctor. I think there's going to be some studies that'll be coming out hopefully soon in that very thing, so that we can start to say that this is what the dosing recommendations are, this is what it works for. And I think that's what we really need there, is to know more about what it does, how it helps, and what the dosing ranges are.
All right, I have one more. Can you speak to the use of the ketogenic diet to modify PWS behavior?
Yeah, so again, I have lots of people doing it. I still, the jury's out. So my thought is I have parents who say it's the, best thing ever, and that's great. But I don't think that the data really supports that so far. So my thought is if it helps your kid, that's great. But until the data really backs up that it makes a difference with behavior, I'm again one that, if you want to try it and you have a doctor, overseeing it and doing that, that's great. But again, there's not been enough data, really been no data collected on it in a really controlled way to show that it works. So jury's out. I'm not going to definitely recommend it to anybody, but if you want to try it and you have somebody overseeing it and supervising and monitoring it to make sure there's no other issues, then it's something, if it was my kid, I'd give it a try.
All right, I think we will just ask you one more question. You had mentioned earlier that you would be willing to have people send you an email if they didn't get a chance to ask questions during the webinar. And a few folks have asked if you would provide your email address.
Yeah, it's really,
do that.
It is my first name, Elizabeth, all little letters, .roof, ROOF, @vanderbilt.edu. It's been my email for like 28 years. So feel free to email me, and I may answer you and just set up an actual phone call. If it's something pretty short, I can email you an answer back. But I would be happy to answer it. If there's a lot of them, it may take me a little bit of time to get to you. So don't despair. I will definitely get in touch with you.
All right. I just had one question come in, and then I think we're going to want to wrap it up for the evening. This mom asks if it's possible. She knows that growth hormone helps with tone and muscle building, but also is it possible that growth hormone could be making her child gain fat tissue?
I mean, obviously I'm not an endocrinologist. I don't think so. So I have heard that, growth hormone only increases lean mass, not fat. So my thought is people with PWS have high levels of fat, even if they're not overweight. So I would say that if your endocrinologist is monitoring it, I don't see that happening. So I would say, talk to your endocrinologist, but I have not heard of that before, and I don't think that is possible or probable. But again, not a physician, so talk to your doctor.
All right. Well, I want to give a big thank you this evening to Elizabeth Roof for presenting for us tonight and giving us all this wonderful information. I want to thank you all for joining us. And apologizing again for the technical difficulties we had in the middle there, but I think it all came out wonderful. And you will all be getting an email at the end of the presentation with a link to the recording. And as I said earlier, it will be available also on the PWSA USA website for future viewing. So again, thank you so much for joining us, Elizabeth.
You're welcome. Thanks, everybody.
Yeah, thank you all for joining us. Good night.
Good night.